clinical practice, assessing a patient's mental status is crucial in understanding their cognitive, emotional, and psychological well-being. These mental status examinations follows a structured approach to ensure accuracy, confidentiality, and a patient-centered care. Before beginning the assessment, I perform hand hygiene and prepare the necessary materials. Ensuring proper hygiene prevents infections while having all materials ready to help maintain a smooth and professional examination. I ensure that the room is quite well lit and free of distractions. A calm environment helps the patient feel safe and comfortable during the examination, reducing stress and improving communication. I introduce myself to the patient and explain the purpose of the assessment. I reassure the patient that our conversation is confidential unless there is a concern for their safety. Next, I review the patient's history to understand their condition, past treatments, and any relevant medical concerns. This helps tailor the assessment to their specific needs and ensures that their past experiences are considered. The patient has a history of depression and reports previous episodes of hallucinations. The patient have not attempted suicide before, but they mention recent increased feelings of hopelessness. I engage the patient in a calm and empathetic manner, letting them know they are in a safe space. I encourage the patient to share at their own pace, ensuring they feel supported and heard. Maintained minimal eye contact but nodded in response. The body language suggested slight tension but also a willingness to engage in conversation. I observed the patient's grooming, posture, and overall demeanor. Signs of depression, such as poor hygiene or slowed movements, may indicate the severity of their condition. The patient appeared unkempt, with messy hair and wrinkled clothing. Their psychomotor activity was slowed, suggesting possible severe depression. I assess the patient's speech for tone, speed, and fluency. Slow, monotone speech may indicate severe depression, while disorganized speech may suggest distress or thought disturbances. The patient spoke softly and slowly, responding in short sentences with minimal expression. I asked the patient about their emotions and observed their facial expressions to determine whether their affect matches their reported mood. The patient reported feeling sad and hopeless. Their affect was flat with little emotional expression. After that, I evaluate the patient's thought patterns, checking for coherence and signs of distressing thoughts such as suicidal ideation or hallucination. As what I've observed, the patient's thought process was logical but slowed. They expressed feelings of worthlessness and occasional intrusive thoughts of self harm. I explored the nature of the patient's hallucinations by asking about their frequency, type, and impact. Then the patient reported hearing voices that sometimes criticized them. They denied following any commands from the voices but said they felt distress. I assessed the patient's cognitive function through orientation and memory exercise to evaluate their ability to concentrate and process information. The patient was oriented to time and place but struggled with short term memory recall. After that, I carefully document the patient's symptoms, responses, and any critical findings to ensure accurate records and guide future care. I recorded the patient's symptoms, including their depressed mood, hallucinations, and slowed thought process. I discussed coping strategies and treatment options with the patient, ensuring they feel involved in their care plan. I observed that the patient expressed interest in counseling but was hesitant about medication. I scheduled a follow up appointment and ensured that the patient knows where to seek help in case of distress. And the patient agreed to a follow up and was given emergency contact information in case of crisis. After the assessment, the patient appeared slightly more at ease by the end of the assessment.